Welcome. I'm Diane Lavinia, Director of Industry Relations for the IDSA Foundation. Thank you for joining us today for Beyond the Common Cold, RSV's Unforeseen Consequences and Emerging Prevention Options. This non-CME webinar is part of the Dr. John G. Bartlett Memorial Education Series. Special thanks to our sponsor, Pfizer. Before I introduce our host and moderator, a few housekeeping matters. This webinar will be recorded and made available for viewing. If you are unable to stay for the duration of the webinar, feel free to access it on demand at your convenience. A link will be sent to all registrants within 3 business days. As you may have noticed, all attendees have their microphones muted. Please utilize the Q&A button at the bottom of your screen to ask questions at any point during the webinar. If we are unable to address all of the questions during the Q&A session at the end, we'll make every effort to follow up with an email. Now, I'd like to introduce our host and moderator for today, Dr. Mary Rose Lagiovia. She holds the positions of Infectious Diseases Division Chief, Antimicrobial Stewardship Program Director, and Associate Program Director for the Internal Medicine Residency Program at Rochester General Hospital in Rochester, New York. Dr. Lagiovia.
Thank you, Diane. And thank you everyone for joining our webinar today. Hi, I'm Dr. Lagiovia, and I'm truly honored to moderate today's webinar on RSV. RSV is such an important cause of respiratory infections worldwide, and today's webinar is a real treat, particularly for those interested in learning about RSV prevention in vulnerable populations. We are going to hear more about this big beast in infectious diseases from research scientists who have dedicated their careers to it. They are the giants whose shoulders we stand upon today. As a reminder, our speakers will cover the nature of RSV and the specific concerns it poses for infants and older adults, as well as identify prevention and infection control for the upcoming respiratory virus season. Now, it is my pleasure to introduce Dr. Edward Walsh. Dr. Walsh received his undergraduate degree in chemistry from Manhattan College and an MD degree from SUNY Downstate in 1974. He completed his residency at the University of Rochester Medical Center's Strong Memorial Hospital in 1977 and a fellowship in infectious diseases in 1982. He is currently professor of medicine at the University of Rochester and former head of the infectious diseases unit at Rochester General Hospital. I had the pleasure of working with him for over a decade. His research activities are focused on many aspects of RSV infection. These include characterizing the function and antigenic characteristics of the viral proteins, primarily the F and G glycoproteins. This work also involves study of their role as potential vaccines in animal models of RSV infection. His clinical research has centered on describing the epidemiology and clinical characteristics of RSV infection in pediatric and adult populations with an emphasis on high-risk and elderly populations. Recent lab work has been directed at describing immune correlates of protection in infants and high-risk adults, and ongoing work includes studying the pathogenesis of disease severity in full-term infants with primary RSV infection and in clinical trials of the Prefusion F vaccines in RSV adults. Dr. Walsh, take it away.
Thank you, Mary Rose, for that introduction. Can we have the next slide? It's been an exciting year for RSV at all levels, from an epidemiologic point of view, as well as for preventive therapies. I'll first review very quickly the burden of RSV in young infants. It's worth pointing out that half of all infants are infected in their first winter, with the remainder by age 2. And that RSV is the single leading all-cause hospitalization in infants under a year of age, averaging about 9% of all admissions throughout the year. And during peak seasons, as shown on this graph, greater than 20% during the winter. And estimates are anywhere from 33,000 to 92,000 total admissions annually. Next slide, please. Now, RSV is also the leading cause of radiographic pneumonia in children ages 1 to 5 in Asia and Africa, as shown very nicely in the PERCH study, and global estimates of approximately 3.6 million hospitalizations worldwide. As shown on this slide, you can see RSV outnumbering those causes of pneumonia, including other viruses and bacteria, including pneumococcus. Next slide. 1 to 2% of all newborns are hospitalized in their first winter. We all know about the high-risk groups, those who are severely premature and those with underlying immunodeficiencies or cardiopulmonary disease. But it's also important to note that the vast majority of hospitalizations are actually in the healthy full-term infants. The incidence of hospitalization with RSV in children under 2 is greatest between birth and 3 months of age. And this slide demonstrates the hospitalization incidence rate over the first 2 years of life. And I will point your attention to these first 3 to 4 months, which is the area in which we need to focus our attention on prophylaxis. Next slide. Additional impact of RSV in infants, be about 500,000 emergency room visits in the US, 1.5 million office visits, and fortunately, only 28 to 80 deaths have been estimated to occur from this. But then there's long-term effects, such as possible links to causally related to asthma in later childhood, adolescence, and adulthood. And I might point out that although very few people or infants are at risk of death in the US, worldwide, 101,000 deaths are attributable to RSV in children under age 5. Next slide. In regard to diagnosis and management, it's fairly straightforward. The clinical evaluation and knowledge of viral epidemiology is a relatively accurate way to diagnose RSV, although for confidence, RT-PCR is considered the primary diagnostic tool. And I've listed some of the supportive care that is generally directed at infants with RSV, which includes fluid, O2 supplementation, antipyretics. But glucocorticosteroids, bronchodilators have never been proven to be clearly effective in large-scale studies. There is no good antiviral therapy that is used in most infants. And currently, we do not have any active antiviral treatments for this disease. So prevention really is the key factor in dealing with RSV in the infants. Next slide, please. Now, before we start into what's available and what's coming available in the next few months to years, I'd like to just review a little bit about RSV on the molecular level. This is an enveloped virus, and as shown on this slide, the 2 major proteins on the envelope are the attachment protein shown here on the left. This is a highly variable protein. It is used to describe 2 groups, A and B, with multiple genotypes. The fusion protein, on the other hand, is considered rather conserved between both group A and group B and within the multiple genotypes. And I would point out that neutralizing antibody to either one of these proteins has been shown to be protective in animal models. Next slide, please. So for prevention, we now have newer monoclonal antibodies and vaccines to discuss. And I show this slide only to show you that it's been about 60 years since we've started this journey. In 1956, the virus was identified in monkeys, but then within a year in humans. The first vaccine trials were in 1966 with a formalin inactivated vaccine, and this resulted in enhanced disease and really stalled a lot of progression and research in this area of vaccine development. And I might point out in the 1970s, Paul Gleason at the Baylor University was the first to notice that neutralizing antibodies and cord serum were correlated with the time at which a child became first infected with RSV and hospitalized. So the concept of maternal immunization, for instance, really goes back to these early studies. The viral protein, fusion protein, was first identified in the 1980s. Live attenuated RSV vaccines were started in the 1980s, and these continue to today, and I will not discuss them in any degree during this talk. And I might point out that in 1998, the currently available palivizumab monoclonal prophylaxis has been successfully used. And then the last piece of information is the really landmark work that was done at the NIH by Barney Graham, identifying the different forms of the fusion protein. Next slide. So the fusion protein, as pointed out, it carries neutralizing epitopes, but it was really this work in 2013 by Dr. Graham that showed that the neutralizing epitopes on the pre-fusion protein are distinctly different than those on the post-fusion fusion protein. And it really was this discovery of these multiple epitopes, some of which are more potently neutralizing than others, that really has led to the development of both the new vaccines and monoclonal antibodies. Next slide. So why maternal immunization to protect infants? Well, there's long established safety and benefit of vaccination during pregnancy to prevent tetanus, pertussis, and influenza. There's, as I mentioned, higher levels of maternally transferred neutralizing antibody correlates with protection. And there is the 20-year demonstrated benefit of passive administration of palivizumab to high-risk infants. Next slide. So the first study I'll discuss is the phase 2b study of a bivalent prefusion F vaccine that was given during pregnancy to approximately 1,500 infants. In this study, as shown here on this upper panel, it shows that in the placebo group, the mothers have equivalent neutralizing antibody to both group A and group B virus, shown in the different colored bars. Following vaccination with 120 micrograms of bivalent prefusion F, the titers rose approximately 10 to 12-fold. And the bottom panel shows that this antibody was then transmitted at a slightly greater than 1-to-1 ratio to the offspring. Next slide, please. And if one were to extrapolate this increase in antibody, as shown here in the blue line, over the first 6 months of life, you can see that the antibody continues to be above what is a theoretical protective level that palivizumab would provide. And the gray line shows the placebo group with their slow fall off of antibody that actually falls below protective levels by about 1 to 2 months. And this is the period of greatest need for protection. Next slide, please. So the following study was the phase 3 trial, and this was a double-blind randomized placebo-controlled trial. It was done in 18 countries over 4 seasons and involved approximately 7,000 women who were vaccinated between weeks 24 and 36 gestation. The primary efficacy endpoints were medically attended severe respiratory syncytial virus lower respiratory tract infection at 3, 4, 5, and 6 months after birth. Secondary endpoints were RSV-associated hospitalizations and all-cause LRTI. Of special interest was preterm birth, low birth weight, and developmental delays in terms of safety efficacy or safety endpoints in these phase 3 studies. Next slide. This shows data from a phase 3 study using this vaccine, the bivalent prefusion F vaccine, in preterm infants between age 29 to less than 35 weeks, a group that is not currently being given palivizumab. And what this shows is that nirsevimab was highly effective at preventing first medically attended RSV lower respiratory tract infection. Next slide, please. Here we go back, fortunately, to the vaccine study. This is medically attended severe RSV-associated lower respiratory tract infections. And you can see here at 90 days after birth, there's 81% efficacy. And this is shown graphically in the gold with the vaccinated group compared to the placebo group over the first 180 days. And this vaccine efficacy of 81% was fairly persistent through day 180 with 69% efficacy. Next slide, please. This is a second primary endpoint, and that is medically attended RSV-associated lower respiratory tract infection. And this also shows approximately 60% to 50% efficacy over the 180 days of the study. Next slide, please. Other endpoints included efficacy against hospitalization, as well as medically attended RSV acute respiratory infection of any type, and that was about just under 40%. There was no benefit for all-cause LRTI. Next slide. One of the safety issues that was brought up, and we'll talk about it a little bit later, was a slight imbalance between the placebo group shown here in blue and the vaccine group in gold of premature delivery and also low birth weight infants. And although this was not statistically significant, this did result in some modifications in the final FDA decision on licensing. Next slide, please. So some limitations regarding vaccination. One is that the studies excluded high-risk infants or high-risk pregnancies. It was limited data from low-income countries, and there really wasn't enough data to assess group-specific sensitivity of the vaccine. Concomitant vaccination with Tdap and influenza vaccines, although thought to probably not be an issue, really was not studied in these trials. And as mentioned, there was this imbalance in premature births in the phase 2 and phase 3 trials. On August 21st, just a week ago, the FDA approved the Bivalent Prefusion F vaccine for prevention of RSV in infants through active immunization of pregnant individuals 32 to 36 weeks gestation. And the reason for not including 24 weeks through 36 weeks has to do with the concern of possible imbalance in terms of premature births. And it was thought that by moving the window from 24 to 32 weeks up to 36 weeks, you would reduce the likelihood of this potential side effect. Next slide, please. So now we'll move to monoclonal antibody prophylaxis. There's 20 years of experience with palivizumab, which shows safety and benefit. And I want to point out there was a phase 3 trial using another monoclonal antibody, actually a site 5 monoclonal antibody, that failed to meet efficacy endpoints due to spontaneous mutation at the active binding site in what was then the dominant RSV group B strain in circulation. And I just point this out because this is one of the concerns that we always will have when we use monoclonal antibodies for prophylaxis. This was so clear in the during the COVID pandemic as the monoclonal antibodies lost their efficacy as the virus mutated. Now, fortunately, RSV does not, especially the F protein, does not have much in the way of mutations, but they can spontaneously occur as occurred in this study. And most importantly, with the newer monoclonal antibodies, is the ability to develop long-acting ones that persist through an entire RSV season by altering the FC portion of the antibody. And this has allowed single dose for an RSV season. Next slide, please. So the new monoclonal, long-acting monoclonal antibody, nirsevimab, is directed at site 0, which is the most potent of all the neutralizing sites. And there is another monoclonal antibody in clinical trials now for site 4, which also is long-acting and broadly neutralizing. I won't be talking about that. Next slide, please. So this is results in the phase 3 trial in preterm infants between 29 and 35 weeks of age. That's with nirsevimab. And this study of 1,500 infants You can see that the hazard ratio for risk of hospitalization was 0.19. So it was highly effective at preventing hospitalization during this study. And I might point out that ICU care was needed in none of the nirsevimab receiving patient individuals, where there were 5 infants in the placebo group that required ICU care, 4 of whom required assisted ventilation. And I might point out, as I noted before, 2 RSV isolates in this study did have decreased susceptibility to the monoclonal antibody, but none were fully resistant. Next slide, please. And this is the phase 3 results in late preterm and term infants with this Site 0 nirsevimab monoclonal antibody. And what this data shows, which was published in 2022 in the New England Journal of Medicine, shows that it was 74% effective at preventing medically attended RSV-associated lower respiratory tract infection, and also 62% effective at reducing hospitalization, and there were no safety signals. Next slide, please. And this is simply showing medically attended RSV-associated lower respiratory tract infection. And this also was quite effective, as shown here in this slide, with a hazard ratio of 0.23. And I would point out that drug levels exceeded what were thought to be protective levels through day 180. And it's also notable that anti-drug antibodies may develop in some of these infants, although it did not appear to alter the effectiveness. This was primarily a Group A year when this study was performed, and no resistance was noted in the viral isolates. Next slide, please. So on July 23rd of this year, the US FDA approved, and on August 3rd of this year, the ACIP and CDC recommended nirsevimab for infants less than 8 months of age, born during or entering their first RSV season, and for infants aged and children ages 8 to 19 months who are at increased risk of severe disease entering their second season. And that would be the group of infants who have high-risk conditions who are at risk for RSV during their second RSV season. Next slide. So in conclusion, after many years of research, there are 2 effective means of preventing RSV serious disease in the youngest and most vulnerable infants that will be available. Studies to determine their optimal use are still to be decided upon, and careful assessment of drug resistance, especially with the monoclonal antibodies, will be critically important over the long term. So thank you, and I'll return this to Mary Rose.
Thank you, Dr. Walsh. As a reminder to the audience, please use the Q&A button to ask any questions at any point in the presentation, and we'll address them when we get to that time. Now it is my pleasure to next introduce to you Dr. Ann Falzi. Dr. Falzi is a professor of medicine at the University of Rochester School of Medicine. The focus of her research has been clinical and translational research in the field of respiratory viral infections in adults. Dr. Falzi received her Bachelor of Science degree in biology at Providence College and doctorate in medicine at Vanderbilt. She completed her residency in internal medicine at Strong Memorial Hospital at the University of Rochester and infectious diseases fellowship at Yale University and the University of Rochester. Initially, the focus of her research was defining the epidemiology and impact of RSV in adult populations. More recently, Dr. Falzi has broadened her research to include numerous viral respiratory pathogens, including influenza, coronaviruses, parainfluenza viruses, and human metapneumovirus. She has conducted many adult surveillance and vaccine studies in a variety of settings, including ambulatory older care adult clinics, nursing homes, and senior daycare centers. She has extensive experience in the development and performance of diagnostic and serologic assays for influenza and other respiratory viruses, including cell culture, RT-PCR, and neutralization assays. She's presently the co-PI of the Rochester Vaccine Treatment and Evaluation Unit and conducts vaccine and therapeutic studies against SARS-CoV-2. She has been involved in RSV vaccine research since 1993 and has helped conduct recent RSV vaccine efficacy trials. Thank you, Dr. Falsey, for joining us today.
Well, thank you, Mary Rose, for that kind introduction, and thanks for having me to talk about my favorite subject, RSV in adult populations. Next. I thought it was worth, before diving into the vaccine research, to talk about the burden of disease and something about the clinical manifestations, since sometimes internists and family practitioners are not as well aware of RSV compared to pediatricians. And even though at the outset, when it was first discovered, it was understood that RSV could reinfect adults, it was generally felt to be quite mild and pretty much ignored for 20 years or so. It's in the 1980s that there started to be some outbreaks noted in nursing home settings. And the attack rates could be quite high, and even with very high rates of pneumonia and death. In prospective studies, it ranges from 1 to 15% infection rates in a year. But what's important to remember is that only about 5% of older adults live in nursing homes. Next. So to get a sense of what was going on in the general population, one way to get at it are modeling studies. And this is now somewhat of an old study, but it really shows us the results of a whole field. And so what they do is they correlate events in all ages with respiratory detections. And generally, the positive tests are in children. And they correlated here RSV and flu detections with the annual census death data due to pneumonia and influenza and circulatory and respiratory deaths. And you can see here that in RSV, the young child dominates. And this is, as I said, a little bit old study. And so fortunately, those rates are lower now. But what took people by surprise was the estimate that nearly 2,000 middle-aged adults and around 11,000 older adults were dying each year from RSV. And this was really flying under the radar. And it's because, again, RSV is reinfection. Adults have less recognizable syndromes, and the viral load in the nose is less. So it's just harder to make a specific diagnosis. Next. So we like modeling studies just fine, but decided to embark, Dr. Walsh and I, on an epidemiology and impact study. And it was 4 winter seasons, prospective surveillance of healthy older adults living in the community. And then what we deemed to be high-risk adults, which was those individuals with cardiopulmonary disease, typically heart failure and COPD. And at the same time, we looked at any adult hospitalized with an acute cardiopulmonary condition. And to address the issue of it's hard to make a diagnosis, we used both PCR and serology, acute and convalescent serology. And we used influenza A as our yardstick to compare, whether we thought that this was important. Used a very broad evaluation trigger, and we were making home visits. So it was really a very comprehensive study. Next. And so shown in blue is the result of that study. The infection rates of RSV were 4.8% in our healthy, 6.5% in our high risk. Roughly 30% made office visits. And you can see that if you were healthy and older, you did okay, but the high risk adults were being hospitalized, and we even had a few deaths. Now, these type of studies are extremely difficult to do, and really it wasn't until Corsten et al. In Europe just a few years ago repeated that study. And you can see that they were following fairly sizable cohorts of older adults, and they got nearly the identical results. And again, they used PCR and serology. So 4.2% one year, 7.2% the next year, and about 31% were making office visits. Probably was a little bit healthier population, so they didn't have hospitalizations and deaths, because it really takes an effort to get those high-risk individuals into a study. Next. A little bit less is known about medically attended disease in adults, but there are a few studies, and this is just one from the Marshfield Clinic. And what they found was 15.4% of, or the incidence per 1,000 were visiting a doctor for a respiratory complaint. Now you can see it was a four-year study, and over the different seasons, it was relatively constant. And the visit rate goes up with increasing age. And importantly, 6% of those who visited their doctor as an outpatient progressed to a hospitalization. Next. Now, we mentioned that the disease burden is probably quite under-recognized, and there's a couple of reasons for that. We thought that once PCR came in that, it would be super sensitive and a nasal swab. If it's negative, that means you don't have the disease. And this is just one study showing that the nasal swab maybe is not the best specimen. In 1766 adults, they all had nasal swabs. 3.2% were positive for RSV. If they tested saliva, which was readily available in most people, it went up to 4.3%. Sputum was the highest yield at 6.8%, and serology was also quite high yield at 6.3%. Now, you'll also notice that they didn't get sputum in serology in many people. So it's a good specimen if you can get it, but you can't always get it. Next. So if you just look at the type of sample that's immediately available at the time the person has the illness, nasal swab, saliva, and sputum, the yield increases 66% over just a nasal swab alone. So we have to keep that in mind when we are looking at studies that are really relying on just a single nasal PCR. Next. So I think now we started out with the question, is the adult burden of disease big enough to warrant a vaccine program? And now there's lots and lots of evidence from various countries and investigators that there clearly is a need. Next. So just to review, what does RSV in an adult look like? Well, it can be highly variable. It can be really nothing more than a cold. Or it can progress to severe pneumonia or respiratory failure and everything in between. Next. If we look at people hospitalized with RSV, some prominent symptoms of RSV compared to influenza A are nasal congestion, shortness of breath, wheezing, and also sputum production, which isn't listed here. Next. Influenza A, however, the fever is more of a prominent symptom. And so while if you do studies and you compare overall signs and symptoms, you can see some significant differences. There's so much overlap, and that's one of the problems with RSV is you don't recognize it. You really need a diagnostic test. And so it really is PCR in clinical practice. I would encourage people to collect a sputum if they can, but PCR is the way to go. Next. And one thing that I'd like to just point out is that the lung disease is so very different than what we were seeing with something like COVID. This is a lady who came in from one of our prospective studies. She was in fact culture positive for RSV, only had been sick a few days. And she was so hypoxic in the emergency room, and this X-ray is not all that impressive, that she ended up having a CT scan to rule out a pulmonary embolism. And you can see these very little wispy infiltrates. True widespread viral pneumonia is not that common. RSV pathogenesis is yet to be completely worked out, but there's a lot of airway reactivity and secretions. Next. So when comparing the outcome of people hospitalized with RSV shown in blue and flu shown in red, they're really very comparable when you look at pneumonia, respiratory failure, and death. Next. More recently, there's been some data, however, that RSV patients fare worse than do influenza patients. And this is showing survival over 12 months following the respiratory hospitalization. And RSV, you can see in red, the patients fared significantly worse. They had longer lengths of stay, they needed more oxygen, and at discharge, they needed more services. Next. So who exactly is at risk? Age is just a number, and not older. All older people are alike. Next. So age specifically, if you're old, makes a difference. So this is again modeling study. It is from the UK. And what they're showing on the top is hospitalizations per 100,000. Deaths are shown on the bottom. And the green line is people ages 65 to 74, whereas the purple line is those individuals over 75. So you can see that the green line is elevated amongst adults, but it's really when we get to really advanced age, you're at significant risk. Next. If you look at other risk factors, and this was a very nice multivariate analysis by Wiffels et al., you can again see the significant factors are shown in the light blue, that age, increasing age is a risk factor, but COPD, CHF, hematologic malignancies, stroke, and then chronic kidney disease. Next. The impact is also not just the hospitalization. So looking at function, which is very important to older adults, about 40% were living independently when they were admitted. Next. And 14% had a loss of independence at discharge. And that's not unexpected when you have an acute illness. Next. But 8% had ongoing loss of independence 6 months after the hospitalization. So that's something we really would like to avoid. Next. So when you think about vaccines in adults, it's perplexing. It's all reinfection. We all have nasal and serum antibody. And unlike influenza, antigenic changes don't seem to be as important. So the observational studies have shown us that more antibody seems to be better, both in terms of risk of infection or risk of hospitalization. Next. And so the vaccines came along, and Dr. Walsh gave a good explanation of the new generation Prefusion F vaccines. And so the current candidates for adults are protein vectored and RNA, and it looks very similar to what we had for COVID. Now, the protein vaccines are GSK, and that is adjuvanted with AS01. And then the Pfizer vaccine is also protein. It is not adjuvanted, and it is bivalent for group A and B. The vectored vaccine was Janssen, and that they use the same vector that they did use for COVID, the Ad26, a replication deficient adenovirus vector. And then Moderna has developed an RNA vaccine. Next. So I'm not going to get too granular, but the GSK vaccine was approved. Their phase 3 efficacy trial was very successful. It was FDA approved on May 3rd. Pfizer came next, and it was also successful, was approved by the FDA on May 31st. Moderna is released their top line results and is undergoing FDA review. And Janssen looked great in 2B. Next, but they abandoned their program, and it's probably because they felt like they couldn't compete. And the Bavarian Nordic's program failed in phase 3. Next. So top line results and the big efficacy trials were geared towards preventing 3 or more lower respiratory tract disease symptoms. And it's shown here that they're all, as you can see, over 80% effective to prevent lower respiratory tract disease. And it surprised me also that they were protective against any ARA, somewhere 60 to 70%. Now, the pandemic resulted in low cases during these trials, which they did meet their endpoints, but it gave us some wide confidence intervals because of the number of cases that were low. Next. So the FDA approves, and then the ACIP recommends, and this the ACIP reviewed both the GSK and Pfizer vaccines in June, and they published their recommendations in July in the MMWR that you can see here. And the table on the left shows the efficacy of the vaccine over 2 seasons. In the first season, it was 82.6% effective. The second season, 56.1%. It was also effective against medically attended disease. If we move over and look at the side effects, because it is adjuvanted, there was a little bit of local reactogenicity, but they also had 3 neuroinflammatory events. One was a case of Guillain-Barré, and 2 were ADEM, which probably will be subsequently discounted. They were very poorly documented. Next. And this is the data from the Pfizer trial, season 1 and season 2, 88.9 and 78.6% effective. So it really looks like these vaccines will get us through 2 seasons, and also 84.6 for medically attended disease. Again, if we move over to safety, not very reactogenic because it wasn't adjuvanted, but again, there were these neuroinflammatory events. There was 1 case of Guillain-Barré, 1 case of Miller-Fisher, which is a variant, and then a polyneuropathy, a pre-existing polyneuropathy that subsequently got worse. Next. Now, it's because of the safety, but a lot of other reasons, that the ACIP deliberated and decided what they would recommend is that an adult over 60 may receive a single dose of the RSV vaccine through shared decision-making. The factors they considered were safety, the lack of very old or very high-risk populations in these trials, and again, because of the pandemic, the cases were low, so they couldn't comment on hospitalization and death. Next. So these are the risk factors that you might consider. It looks an awful lot like the old risk-based flu vaccine recommendations. Next. So the problem with shared decision-making in adults is that RSV really has an identity crisis. Next. This is one small study where they did a knowledge test in providers, family medicine, internal medicine, and they asked them, how often do you see adults with RSV? And you can see highlighted in red, you know, some were rarely and some were never. And so clearly those folks are not thinking about it in testing. And then I guess most disturbingly, 85% could not name the major risk factors for being high risk, age over 65 and cardiopulmonary disease and being immunocompromised. So I think that we've come a long way, but we have a lot more work to do to really bring these vaccines into the clinic and help our older adults. Next. So just to sum it up, RSV probably affects about 3.4 million adults each year in the US, leading to about 1.7 million outpatient visits, somewhere between 100 and 177,000 hospitalization, and 8 to 14,000 deaths. So I will next stop there and turn it back over to Mary Rose.
Oh, thank you, Ann. Thank you very much. And also, if Dr. Walsh, could you turn your camera and unmute yourself, come back on? We'll start our question and answer portion. Again, there are lots of great questions in the chat, so I'll try and organize them one by one. So first, to Dr. Walsh, there were some questions about nirsevimab. One is, what is the cost? And 2 is, assuming that nirsevimab is widely available in the United States, is the expectation that maternal vaccines would then be primarily used in low and middle income countries without access to the monoclonals? Or what would be the role between use of maternal vaccination now that nirsevimab is approved?
Yes, well, those are good questions. The cost is the only one where I think we can give a definitive answer, because cost pricing it seems to be solidifying for nirsevimab, and it's somewhere around $495 per dose. The recommendations for its use are dose-based, or they're weight-based. So there are actually two different doses for the youngest infants. And then for the older infants who will be at high risk entering their second season, there is yet a third dose. And so it'll be, you know, generally the price is around $495 for programs that use the VFC, or the Vaccines for Children programs. The price, as far as I am aware, is about $100 less. So I think we can answer that now. Whether there will be differences in insurance company payments and so forth, this is something that's currently under discussion, I'm sure. With regards to the problem we have now, in a sense, it's a very good problem. We have two successfully shown successful ways of dealing with the very youngest infants, and you've got vaccine, and you've got long-acting monoclonal antibodies. Currently, the nirsevimab is FDA approved, and it is ACIP approved, and also the recommendations are for using this drug in all infants at this point. What exactly will take place? I think the hospitals, as well as pediatric practices, are now working these logistics on implementation. As far as vaccine goes, it is not, we have not seen the ACIP weigh in yet with their recommendations. We've only got the licensure data, or licensure approval from the FDA. And ACIP will be meeting, and CDC will be making their recommendations sometime in the near future, but perhaps not soon enough for this current winter. Of course, we don't know when RSV is going to come this winter either, since things have been a bit disrupted over the last few months, or last few years, as I think most people are aware. We're hoping things are back to normal, but we'll see. It does create, you know, some interesting issues. For instance, you could even consider the possibility that you would have an infant who was born to a mother who was immunized with the vaccine, born with high levels of neutralizing antibody, but then have exposure later in that first year, entering their first winter. You know, sort of the tail end of the benefit of the vaccination, who could then conceivably also receive a monoclonal antibody. So these are logistics that need to be worked out at this point. And so it's difficult to say. The cost of the vaccine is less than nirsevimab. It is currently set in the roughly $250 to $280 range. I don't know if I've seen a final cost per dose, however, at this point.
Okay. All right, now coming back to that point you brought up about timing, and either you or Dr. Falsey, you could answer this question too. In light of the seasonality, would there be any advice that you would have for timing of the vaccines, either in adults or in pregnant women? And then also, similar to that, it kind of goes into the implementation science of creating a vaccine campaign. Who would be the targeted providers that you would try and promote increased awareness and availability of these vaccines? Would it be primary care physicians within the hospitals, obstetrics, gynecologists, et cetera?
Yeah, well, I'll address, you know, obviously the infants initially. The current recommendation is that the monoclonal antibody would be administered in the hospital at birth, before discharge. the same way we are doing hepatitis B vaccination at birth. Whereas after discharge, it would then be left to the pediatric offices or general practitioner offices to administer this vaccine. And the latter does, introduce some logistical issues that the practices will have to deal with. Certainly, you could imagine a practice that has thousands of potentially thousands of young infants in their practice coming in all just prior to the RSV season to receive an injection of a monoclonal antibody. With regard to the vaccine timing, well, this is really for it's going to be decided upon by the gestational stage of the pregnancy. And I'll let Dr. Falsey take the question on the adult vaccine.
Okay, it's a lot simpler. You would probably do it in the fall. The RSV season we expect will settle back into the usual seasonality. But, it does last for 2 years, so the timing is less critical.
We have a few questions in the chat about other at-risk populations. Do you have any opinions about the RSV vaccine in individuals who are either post-transplant or in anticipation of having any transplant done?
Well, those studies are just being done. The immunocompromised patients were excluded from the big phase 3 trials, but they are recognized as a significant risk population. So the major manufacturers are looking at those individuals, and they're also looking at booster doses, second doses. So I think we did learn things from COVID.
Okay, so it probably is anticipated there will be a need for booster doses.
Well, you would suspect there will be, but we don't know yet.
Has there been any analysis in low-income populations to see if there's similar efficacy trends in those populations, such as in Native American or African American patients?
Are you discussing adults or babies?
Either.
Either. Okay, so I think you could criticize the big trials for being less diverse than we would like them, as well as not having a lot of very elderly and high-risk conditions. So I do think, again, we learned from COVID that when we looked at vaccine efficacy and immune responses by race, that it did not seem to impact the efficacy of the vaccines. But these trials were not powered to really do an ethnicity or race-based efficacy. We are starting to understand that RSV in adults, there are socioeconomic differences in risk, and that populations of color seem to be admitted to the hospital at younger ages and have, it's probably healthcare disparities. So it's an important thing to look at.
Still, regarding vaccines, do you anticipate a combination vaccine will be available, or do you have any comments on if these vaccines could be given at the same time as other vaccines? Will it be any impact on the immune response to the other vaccines?
Well, and that's a very important question. Both of the currently licensed vaccines have been studied with concomitant flu vaccine, and they were judged to be non-inferior. That is, the flu vaccine didn't interfere with the RSV immune response and vice versa. But if you really look at the data closely, there may be a very slight suppression in flu titers. The easy answer is you can get them concomitantly. If you have to, if you are a very detailed oriented person, it's easy for you to space them out by a couple of weeks, then go right ahead. Nobody has studied triple vaccination. And I think that just because of side effects, COVID, flu, and RSV, I would be disinclined to give everybody all of them at once.
With regard to the pediatric situation, in terms of the vaccine, currently Tdap and flu are commonly given during pregnancy because they've been shown to be very effective, both for the mother and for the infant. There was no concomitant vaccination with these to be studied in the vaccine trials in pregnancy. However, in non-pregnant women of childbearing age, they have looked at the concomitant administration of the RSV vaccine and Tdap. And that does not seem to indicate a significant impairment of responses to either. And as pointed out by Dr. Falsey a minute ago, the studies in adults, both women and men, there does not seem to be a significant diminishment in the influenza response when given concomitantly. Whether that will hold true in pregnant women, would have to be determined. And it's quite, as she pointed out, the vaccination for influenza is very seasonal in the adult population. In other words, it's given when the virus is around. Well, the same is true for flu. We will tend to vaccinate women for influenza when pregnant during the flu vaccine period.
Okay. We have about 1 more minute, and I don't want to overlook some of these questions about diagnostics. Just one comment, if you could, either Dr. Falsey or Dr. Walsh, what do you think would be the best specimen to provide to diagnose a patient? Let's say for somebody who is either in the emergency room or someone presenting to the clinic, and then someone for an inpatient. We looked at data for differences in saliva and nasal swab. What would be your advice to the provider?
So I think if somebody is coughing up sputum, I would grab it if they're not, because that can be challenging. Saliva really is looking to be second best, and almost everybody can spit in a cup. The saliva is used for, the sputum and saliva can be used in the automated PCRs. You basically swish the swab around in the secretion, and then it gets put into viral transport.
All right, well, thank you. Thank you. We're just about out of time. So if we missed any questions, we will do our best to answer you via email. Thank you again, Dr. Walsh and Dr. Falsey, for your excellent presentations. And I will pass it back to you, Diane, to close out.
Great, thank you. Thank you so much. And again, thank you to Drs. Falsey, Walsh, and Lagiovila. This was another great webinar and such insightful information that you shared. Thank you also to our audience. We're grateful for your attendance and participation in the Q&A. If you wish to revisit this webinar or share it with others, a recorded session will be made available on our website and YouTube channel. In addition, you will receive a link in a follow-up email within 3 business days. I also invite you to connect with us on our social media channels. And then if you're interested in becoming a member of the Infectious Diseases Society of America, please don't hesitate to reach out to us or visit our website. ID Week will be taking place this year in Boston, October 11 to 15th. So there's still time to register if you haven't done so. And if you have, we look forward to seeing you there. The next Bartlett Memorial Education Series program will be on Thursday, September 7th at 1 p.m. Eastern, 10 a.m. Pacific time, focusing on MGen. If you're interested, a registration link to that has been provided in the chat. And finally, we ask you to consider furthering your support of the IDSA Foundation through a personal donation. Your contribution plays a pivotal role in advancing our mission of workforce development and making a tangible impact in the field. Thank you again, and have a wonderful rest of your day.